next I'd like to invite Nikos Darlis, all the way from Athens in Greece, who will teach us about carpal ligaments, anatomy and kinematics.
Okay, good morning. I'm from Greece. I'm president of the American Society for Surgery of the Hand. Thank you for having us as guests of the society this year. Well, talking about kinematics at 6 a.m., it's never easy. It's never easy any time of the day, but I'll give it a try. So if you want to understand kinematics, you have to think rows. You have to think that there are two joints, radiocarpal and midcarpal, and the motion depends on the motion pattern that you are studying. It's different for radiocarpal and midcarpal joints, and different motions in different planes occur simultaneously. If we study flexion extension and radial and molar deviation, there's this great video from the University of Lyon that shows that in flexion, predominantly flexion happens in the radiocarpal joint and less so in the midcarpal joint, but simultaneously the proximal row pronates. On the contrary, if you go to extension, most of the motion occurs in the midcarpal joint and the proximal row supinates. And when you move to radial and molar deviation, although one wouldn't think that this would happen, the proximal row pronates and supinates as we move from ulnar to radial deviation. So it's a very complex motion. How can you make it more easy to understand? If you study another range of motion, which is from dorsal and ulnar to palmar and radial, what we call Dartrose motion, then in flexion you have only midcarpal motion. In extension you have only radiocarpal motion, but in none of these movements, any of the there's no intercarpal motion. Basically, scaphoid and lunate do not move when you're in the Dartrose motion, which is very convenient if you repair a nasal ligament and you want to mobilize early. You can mobilize in the Dartrose motion and be relatively safe. As you heard before, the scaphoid flexes with radial deviation and axial load. So in ulnar deviation it's extended, in radial deviation it's flexed, and this is why we ask our scaphoid views to be in ulnar deviation to see the scaphoid extended in its whole length. The movement of the scaphoid in the triquetrum is coupled. That means that when the scaphoid flexes, the triquetrum extends, and this is because the most strong part of the scapholunate ligament is dorsal, and the most strong part of the luminotriquetral ligament is palmar. What Mark Garcia from Spain taught us, and I think it's very important, is that there's a role of the nerves in these injuries. The ligaments are not cables. They have mechanoreceptors, bacilli in them, which actually give them information about the joint, and this is why one can support the full body weight on a ligament that actually has 20 or 30 kilograms of strength in itself. The thing that what makes it stronger is the fact that there are these reflex loops that activate your muscles when you support your wrist, and so one has to think twice before doing neurectomies when one wants to reconstruct or repair the scapholunate ligament, because it essentially blinds the wrist. Now, the scapholunate ligament in itself, when you first see it in the OR, it's not particularly impressive. There's this strong dorsal part that we all know of. There's a very weak membranous part, and there's the volar part that actually has received little attention, but it essentially is half as strong as the dorsal part. We're accustomed to dorsal tears, but look at this volar tear, which now that we're scoping the joints recognize more and more. This is a mid-carpal arthroscopy, and there's a lot more instability on the volar part than there is on the dorsal part, and these are injuries that we're learning we're adapting to them, and we're trying to figure out what to do with them. All of the above are true when the scaphoid ligament is intact. When it is torn, there's a spectrum of instability, which starts with pre-dynamic and then progresses to dynamic. What's dynamic? In the frontal plane, the scaphoid and the lunate spread apart. But what really causes the long-term effects is the static instability, where in addition to diastasis, you have flexion of the scaphoid and extension of the lunate, what we call a DC deformity. But more importantly, the scaphoid translates dorsally and abarts on the dorsal part of the scaphoid fossa. So if diastasis is a relative problem, the real problem is the dorsal translation, and this is where we see the cartilage wear, the early signs of cartilage wear in the joint, in the dorsal part of the scaphoid fossa. And eventually it will progress to slack arthritis, but this is not the issue of this talk. Now, early on we understood that just by sectioning the scaphoid ligament you would not produce that kind of instability. And over the years we've understood that there are a lot more ligaments involved that have to be torn or attenuated so that you get this injury. Long radial lunate, the STT ligaments, the dorsal and the carpal ligament, and dynamic stabilizers like the FCR. Now, in the early years, we were trying to treat this injury on the dorsal side, but if you see all this stuff, a lot of these stabilizers are volar, and in recent years, we were trying to recreate. You recognize a lot of the ligaments that the ANAFAP procedure now tries to recreate. Marker CLIS, which is the man on kinematics, got it all right, but one thing. He said that the proximal row doesn't have any tendon insertions, which is true, but it does have ligamentous insertions. Mathulin was the first one to describe an insertion on the scaphoid ligament itself, that dorsal capsuloscapholunate septum. But as we're moving forward, we see that we have a lot of capsular attachments both on the dorsal side and on the volar side. And more recently, Scott Wolf told us that there's a real ligament there between the triquetrum and the scaphoid, or a ligament-like structure, and that spans from the scaphoid to the triquetrum. And actually, this can be a valse on its own without any scapholunate ligament. These are MRIs from Australia, from Brisbane, that show that detachment from the dorsal part of the lunate, and that led to this mooring ligaments concept that the lunate is kept in place by mooring lines, and if one breaks, then the lunate will shift into DC or DC, depending on what mooring line is broken. What's the practical implication in my mind? If I'm doing a dorsal capsulodesis nowadays, I want as many anchor points to the capsule as possible. The other thing is that that concept that started as arthroscopic repair, which I was very convinced about, now is becoming a dorsal capsule application. I'm sure Dr. Kamal will talk more about this in arthroscopic procedures, but nowadays we're trying to do large dorsal ligations in early SL ligament in early stages of SL ligament instability. Just to give you what I'm thinking in 2025, in my opinion, the ideal SL reconstruction should address the volar structures as well, either the volar SL ligament or the volar intrinsics, and it other than the SL ligament itself, it should address the dorsal extrinsics either by reconstruction or by capsulodesis. So with that, thank you, and Dr. Kakar, I'm sorry I changed your name.
That's okay.